On.
Yeah.
All right, guys. Dr. Becker, thank you so much for making some great introductions. I know this young lady right here for, I don't know,
a long time.
Yeah, through a change of a couple of administrations, right?
Yes.
And we got some great stories behind that. Veronica Gonzalez with a Z.
Correct.
Yeah. And then in the middle here, we have Dr. Mark Archie.
Correct.
Vascular surgery is your specialty, sir?
That's right. Vascular and endovascular surgery.
Endovascular. And Dr. Mina Archie as well.
Yep.
Same specialties?
Same specialty.
And I'm assuming that you guys have some sort of relationship.
A little bit.
All right.
We're brothers.
All right. Who's older here?
I'm the older one.
You're the older one. So who's tougher?
It depends. We arm wrestle.
You arm wrestle. So what happens there?
50-50.
All right. I'm
That's
sure
a
there's
good
been other
political
type of
answer.
wrestling as well. And probably many fights over the years, right? That's how siblings are, right? I have 4 kids and I know that times can be rough when it comes
Thankfully, we get
close
along.
friends.
Otherwise, I don't think we would be able to sit here
Yeah,
doing
that's
the
great.
same specialty.
Well, I mean, it would be great for our audience to see a little
arm wrestle at the
Wrestling.
end.
arm wrestle or something.
Well, if they stick through till the end, we'll do that.
There we
There
go.
you go.
But thank you all for joining us today. This is our first podcast of the year. And just to give you a little background on the podcast here, we've been able to really attack many subjects, not just things that are in the healthcare realm. I know Dr. Becker, one of your colleagues for many years through healthcare, but as he would tell you, there's more to Morales than healthcare. Some of the episodes that we've had have talked about entrepreneurship, about even physical fitness and mixed martial arts and fighting. And then there was a time where, we talked about tattoos. I'm a little bit blasted up and people kind of are surprised by that sometimes at this point in my life, 47, going like, hey, underneath those long sleeves is actually a kid that made some bad choices, right? But thanks everybody for joining us. We have a really interesting topic that you guys are specialists in. You're actually a stone throw away from us. We're here in Bellflower, and right up the street, you have a vascular center, an ambulatory surgical center, where it seems to me that I've been introduced to you all because of your specialty or your expertise in peripheral arterial disease. Is that what we're here to speak about today?
That's what we're here to talk about.
That's
Right.
awesome. So let's add some color to this. I don't know that everybody knows what peripheral arterial disease is and why it's actually a topic that's worth discussion. So let me start with you, Dr. Mina. What is peripheral arterial disease? Who does it affect? And what are some of the high-level complications that you've seen with peripheral arterial disease?
Yeah, that's a great way to start. I like to explain it to my patients as this. Peripheral arterial disease is the same type of disease as, say, coronary artery disease or coronary atherosclerosis. It's the same disease process. It just happens in the peripheral arteries. Now, what are those? Those are the arteries of the arms and the legs. Predominantly, when we're talking about PAD or peripheral arterial disease, we're talking about legs.
Okay.
And the most common or the best way to describe it is peripheral arterial occlusive disease. That's how the Society for Vascular Surgery describes it. And it's namely the occlusive disease of the peripheral arteries due to atherosclerosis.
Okay.
What are the complications mainly that you asked about, the things that scare people? These are the end stage levels or manifestations of peripheral arterial occlusive disease, which are namely rest pain, dry gangrene, wet gangrene, and oftentimes more tissue loss, which can lead to amputation.
Understood. I have a little bit of a background in skilled nursing facility administration. And of course, in that experience, had to really understand all operations of the organization, including the nursing, the type of rounding they're doing. Wound care was a super big focus for us. And it was so interdisciplinary as far as the approach to attack there. We had our wound care nurse, we had our nutritionist, we had the kitchen, we had different sort of surgeons that may be involved. And I can just say that I don't know a whole lot about PAD, but what I can say is that I've seen less than a handful of patients that have had wounds that just would not seem to progress in their healing. And on a few occasions, they had different sort of procedures related to PAD. And it was like all these months of effort that we put into things, all of a sudden started moving in a matter of days, actually. Is that safe for me to say, Dr. Mark, that this type of procedure could actually have a much more profound effect on the healing of something like a wound versus the traditional and I guess the more holistic approaches of nutrition, wound care, these sort of things?
Yeah, I mean, wound care as it relates to the feet, and that's really predominantly what we're here to talk about. It's multifaceted. We're talking about infection, we're talking about glucose control, and then finally flow, or if the patient has arterial disease, and that's something that we can fix, obviously. When you look at we talk about these things in the context of what we call a Wi-Fi score. We look at infection, we look at ischemia, and if we can fix or control for these things, we can have patients be on the road towards some sort of healing, particularly if they're slow to heal or if they're having even gangrene and they need some sort of minor amputation like a toe amputation. If you don't have enough blood flow to heal that, it's going to be a problem post toe amputation. And so one of the things that we like to do obviously is revascularize patients, improve their blood flow. It's not going to be perfect, but just perfect enough to be able to heal wounds or heal amputation sites.
Got you. And Veronica, you have a major role in making sure that people understand that there are services available.
Correct.
I can say for sure that like when I was in nursing home or whether it's in the dialysis facilities, which has kind of been my life, that I don't hear the term thrown around too often, PAD or any sort of procedure. So what do you see as far as the interaction with whether it be physicians or staff in these facilities, directors of nurses, charge nurses, things like this? What do you see as the roads that we need to take, as well as maybe the misses or the gaps in referral?
Yeah, so the main goal is to work with our podiatrists or our wound care providers to making sure that, they know where to refer to, how easy it is for them to refer to us. Since we're open 6 days a week, Monday through Saturday, it's very easy for just to contact us, and we go ahead and send a referral. We'll go ahead and even check the insurances and make the authorization. They don't have to worry about that, so that's easier for them. And also we provide education to them. So we come out to their practices and provide education to making sure that they know what we're doing, what is it we're doing for the patients, and how we could help them.
Do you feel like that's a well-known area of medicine outside of the vascular side that, folks that are rounding nursing homes, the wound care?
Right. Not everybody's very familiar with it. So that's why we want to come out and help them with that approach and helping them with providing the education so they know what to see, what are the things that the signs for them to refer to us.
Dr. Mina, why is that? Why is it that physicians who have like an extreme responsibility, but also an accountability towards the healing of things like wounds, and we'll talk more about other complications, why is it that there are some gaps in even knowing that this is an option?
I'd say because it's a silent process. The way that PAD progresses, it starts off quietly and patients might not even know. Some patients can even have iliac arterial occlusive disease or an SFA occlusion and not know it until the artery fully occludes, and then suddenly they present with claudication, for example, right? So they're walking along, they're totally fine. Their body does an excellent job of creating collateral flow, right? So these are the branches that anastomose into distal branches in the leg and into the foot. And so the foot and the lower leg does not even know that it's getting less blood flow because the body compensates. And then suddenly something happens, right? And then that's when they show up. And I would say that that's probably the reason why it's confusing. It's confusing for some primary care physicians. A lot of patients suffer from PAD. About 25% of end-stage renal patients suffer from PAD. right? And
I have
perhaps
no
even-
idea.
And perhaps even 10% of the nation, even if they don't have end-stage renal. And so it's a tough issue to diagnose if you're not always doing, for example, pulse examinations on the foot, which are not typically something that you would do.
What's a pulse exam? Sorry, what's a
Mhm.
pulse examination?
Checking the pulses in the foot,
Really?
right? So checking the posterior tibial and the dorsalis pedis pulses in the foot, looking at the foot, making sure it's warm and well perfused, making sure sensation is intact. You know, only a subset of physicians that are used to treating patients with diabetes or with neuropathy or wound care specialists will do something like that.
Yeah.
But that's not necessarily something that would happen at every visit. And that might be one of the reasons why it slips through the cracks.
Yeah. I mean, I think we've got a little bit of example. Claudication. Can you explain kind of
Sure.
that manifestation a little bit?
Yeah, claudication is the presentation of a patient that walks a certain amount of time before the leg cramps. One of the best ways to determine if an end organ is not receiving blood flow is if it starts to cramp and it starts to hurt. A heart attack is when the heart is not receiving enough blood flow, so it cramps. It feels like an elephant is sitting on your chest.
Yeah.
Same exact thing can happen in the mesenteric system. If there are blockages in the arteries feeding the gut, same exact thing. The gut starts to hurt. The bowels start to hurt after the patient eats. It's when you create a situation of demand for that organ. In this case, claudication is creating a situation of demand for the muscles in the leg, mostly the calf muscle. And when the calf muscle doesn't get enough blood flow, it cramps up. When the patient takes a break and stops, the cramp eases off and then they continue to walk. So that's the definition of claudication.
Dr. Mark, older brother. So, you know, as you just spoke to the lower calf muscle and the claudication and that manifestation, I can't help but think back over my 47 years of life, but, you know, 25 years in the profession of dialysis and witnessing and sitting with folks that are on dialysis that have these cramps that I could never even, I just can't understand. I mean, I've had these really tough guys, tough women that sit there and cry over the cramps. And I go like, man, I've been pretty extreme in my life as far as some of the physical exertions that I've done and, you know, the level that I've pushed my body, of course, not today, but, you know, when I was a younger days, and I've had pretty crazy cramps, but I never felt the type of pain that I saw folks that are sitting in the dialysis chair express to me, not just through their verbal, but like just looking at the face, the grimacing, you know, the sounds that are coming from their body as they're cramping. Is this a correlation to those cramps, or is it its own kind of issue, the dialysis, the cramping that occurs during a hemodialysis?
Yeah, that's a good question.
Treatment?
You know, I think in general, you can distinguish. However, there are patients that have PAD and the symptoms of PAD are exacerbated. They're exacerbated during their dialysis session. As you know, renal patients that are on dialysis, they have electrolyte abnormalities, and that is typically the primary etiology for cramping during the session. Or patients that have both end-stage renal disease and peripheral arterial disease, they could have an exacerbation of claudication symptoms. Now they're at rest, right? So they're not walking around. The cramping is likely due to electrolyte deficiency or abnormalities. But if they have rest pain, and rest pain is along the spectrum of severe PAD, the rest pain can be exacerbated. There's a portion of it that's even steel, right? Their access, their fistula, their graft is stealing from other parts of the body. Depending on the flows of the machine, it could exacerbate their PAD. They could have rest pain just during dialysis. And we've seen that patients that they're on dialysis, their hemoglobin's a little low. The last thing they need is really blood to their foot. It needs to go to other places.
All right.
So there's shunting that's going on, and they will have exacerbation at rest.
When you say shunting, can you just kind of describe, because there's a lot of, I think, understandings of shunting. So what do you mean by shunting in this context?
Essentially, like Mina was saying earlier, demand, right?
Mhm.
So
Where it's needed.
if you have a low hemoglobin, right, which we see in a lot of end stage renal patients, and you're on a circuit, right? So extracorporeally, your blood's exiting your body. It's not going to go to a low demand area. And while you're sitting there resting, your legs are a low demand end organ, right? And if you have pre-existing severe PAD, you could have exacerbation of rest pain. So in PAD, you have essentially a spectrum of symptoms. You can be asymptomatic. We can get ultrasounds on virtually anyone and find plaque, right? That's one thing. Then you have claudication. That's demand ischemia. You're walking, you're running, you're going up the stairs, you feel the cramp. The next one is rest pain. Rest pain is very specific. It's not neuropathy. It really is demand ischemia at rest. You're not even using your leg, but your PAD is so severe that any drop in pressure to your legs will elicit pain in your toes, particularly your toes, right? That's called rest pain. Beyond rest pain, you have tissue loss. Tissue loss is tissue gangrene or wounds, right? And so that's the end stage of PAD. So patients that have demand ischemia, they have severe PAD, they could have rest pain with a low hemoglobin on the circuit. They could have rest pain in their upper extremities. You know, most of the end stage renal patients will have PAD essentially below the level of the elbow. Okay. So you'll see some steel symptoms there.
So, wow. I mean, I got to say that we're 20 minutes in, and I've been around this my whole life. So steel syndrome, steel phenomenon, no stranger to me. Cramping during dialysis, no stranger to me. But I got to be honest that I've only really thought about this PAD when I see those patients with ulcerations and wounds that are not healing. So Veronica, I'm curious, since you're out there educating the staff that are on different care settings, caring for patients in nursing homes and dialysis centers, I'm not sure where else you see referrals from.
Right.
What are they coming in for? Like, how do you go out and educate and say, if this is happening, this is happening, this is happening, they should come in for, is it evaluation? Right. What's that
Yeah,
like?
it would be an evaluation. So having any pain or like the doctor said, any having cramps while resting, not even, doing any movements. I mean, there's all these signs to it. And yes, we will have them come in. They'll have an ultrasound before, and then they'll have a consult with the doctor and go from there and see what the doctor sees in those ultrasounds and go from there.
Do you train on like causes and prevention of PAD, or is that something that should be happening on the primary level? Where does that fall into place?
I would say both. I think anytime we can get any of this information out, it's great. It's heartbreaking when you hear the stories of, grandma or grandpa coming in, not having known that there was an issue at all.
Yeah.
And then stubbing their toe. This is an extremely common story. Stub their toe on a piece of furniture, on the leg of a chair, for example. They wrap it up. They take it down a few days later. It's gangrenous. It's infected. Gosh. Anything,
Yeah.
So many different manifestations. They come in 2 weeks later, and now we're suddenly talking about, hey, we need to act on this fast. Otherwise, you're going to have a below knee amputation.
Yeah.
Right. That blows everyone away. And so, yeah, I would say that the education needs to happen as soon as possible and from as many different sources, because that's how we learn, right? If that's something that they were unaware of and now they're getting it from so many different sources, they can slowly process that information and then go from there.
Dr. Mark, what should we be looking out for? I mean, we said, what is it, 10% of the general, and then 30% plus?
About 25 to 30%, yeah, of the end-stage renal disease population.
So let's go, both sides. And let's start with the 10% and kind of the general population. And I got to admit, I'm being a little bit selfish here because I'm gaining in years, right? And, we've talked a lot about it. And Paco's my great buddy here that constantly reminds me, is Morales, you got to, take care of yourself, right? You work hard. You got to make sure that you're feeding your body right and treating your body right to be able to carry on. So I just share a little personal here. I got some high cholesterol, right? And, it's like, well, I'm starting to think now, like that can clog up stuff and, mess my brain and my heart up. Is this also a factor towards PAD? or what are the factors that the general population should be looking at to prevent this sort of issue?
Yeah, that's a great question. I mean, hyperlipidemia obviously has a role in atherosclerotic disease. I think, and this will blow some people's minds, that in isolation is probably not enough to cause PAD or CAD, coronary artery disease.
Hmm.
And you'll see a lot of this, I think, coming in the next decade here. You know, folks have looked into some of the data, and high cholesterol in and of itself is really not the primary driver.
Hmm.
In our practice, what we see, there's really two main groups of patients, right? There's patients with inflow disease, aortoiliac disease, right? And that correlates highly with patients that have a high smoking history,
Really?
smokers.
Okay.
Then there's infrageniculate disease. Geniculate means knee, so disease below the knee.
Okay.
That's patients that are either diabetic or end-stage renal disease.
Okay.
So any factors that contribute to those two conditions will put you at high risk of small vessel disease and honestly limb loss.
So we're
Okay?
talking diabetes, hypertension,
Diabetes,
we're
hypertension.
talking
So
smoking,
you have to look
obesity, all the things, right?
exactly.
Yeah.
Obesity, any of it, believe it or not, if you're obese and you're not a diabetic and you don't smoke and you're not a renal patient, they actually do okay.
Okay.
It's odd. It's an
So
odd
it's those
thing,
other factors
right?
then. Yeah.
So we have to look at PAD and the realm of it being a metabolic disease. Okay. We'll put smoking aside for a second. A lot of the folks that watch this podcast, listen in, are patients that have an interest in end-stage renal disease. So
Right.
what causes that? The two top causes are hypertension and diabetes. Those are the two top causes of end-stage renal disease.
Yeah.
And so we look at it from a metabolic syndrome standpoint. Your cholesterol needs to be controlled. And a lot of the cholesterol medications are anti-inflammatory medications.
Mm.
And so they help, contain some of the disease progression, but it
Mhm.
will not solve it, right?
Mhm.
If you're not watching your sugar,
Mhm.
if your A1C is above 6.5, that's a problem. It's a problem for your kidneys and it's a problem for the rest of the organs. At
Right.
the end of the day, they affect small vessels.
Mhm.
You can think of end-stage renal disease as PAD, right? It's a disease of
Yeah.
the arteries,
Yeah.
the arterioles
Yep.
that go to the kidney.
Yeah. Great way to put it in perspective there.
So
Yeah.
this is really how we view PAD. Obesity in and of itself is really not a driving factor.
Right. You need those other factors.
Correct.
And yeah, we know that kidney disease, limb loss, and blindness are all right in the same alley, right?
Right.
Yeah. Great point. So, when I hear this and kind of seeing the firsthand effects, at least in the wound side, why is it, or how, why and how do we detect this early enough? Let's start with general population, and then of course, then move over to the end stage renal disease population. How do we catch this in time before it becomes that factor of, and I don't know if these are the only factors, maybe let's talk about the others, but before it gets to that point of cramping, before it gets to that point of a wound that won't heal, how do we detect it?
The first sign that a clinician would see in the office is the lack of pulses.
Okay.
Before any symptoms arise, that would be the easiest way without the requirement of any invasive testing to determine that something's off. Now, just because a patient doesn't have pulses doesn't mean they need a bypass or an angio. That's not what I'm recommending.
Mhm.
But that would be the first alert to the clinician, to the physician to say, hey, this patient might have PAD, right? And there is a skill in feeling pulses. It's not as simple as just being able to feel a pulse. So it takes some practice. Now, the problem with that is it requires the patient to take their shoes and socks off,
Yep.
right? You're coming into the office, you have 15 minutes, with the way we practice medical care now, it's challenging. We have time constraints, we have efficiency ratings that we have to meet, et cetera. And so it's tough to do that if the patient's coming in with abdominal pain or a cough. But it's really important because it will allow the physician to diagnose something that may be a silent killer or a silent hindrance to that patient.
Yeah. I can't recall which organizations, but I've known you for a while, Veronica, and met some different sort of champion type of people. I don't know exactly the terms they're using in the dialysis centers. They're really focused on vascular access, but I do remember hearing that in dialysis centers that there are job roles now within even the dialysis technician realm that they do a monthly foot check. And I don't know that that's the norm, but I have heard this through different organizations.
Right.
Would it include those pulse checks? Because I've never heard that. I've more heard of any sort of ulceration and sort of blisters, things like this, and they report to nurse, and then maybe it goes deeper. But
They
how
did
deep is this
used to
going?
do it back then when I was back working in dialysis, but
Mhm.
at this time I haven't heard that they are doing this at this time. But yeah, they did used to have the podiatrists come and check the patients, but at this time I haven't heard anything for them doing that at this time.
I mean, would it be only the podiatrist, or should like the field staff also be doing these sort of checks? Anybody?
It really depends, honestly, on the sort of care that you think your patient's getting. If your patient is really unknown to physicians, they haven't been seeing the doctor, then I think it's prudent to have someone check in. Like Mina said, 1 in 4 patients that are in your dialysis centers will have PAD. And again, we're not treating asymptomatic PAD. We treat symptomatic PAD, and not even all symptomatic PAD. But we have found patients that have end-stage renal disease have end-stage peripheral arterial disease.
Yeah.
It's the same disease.
Yeah.
But it affects their lower extremities.
Mm-hmm.
So should the techs be checking their feet? I don't know. That might be a stretch. It really depends on if that patient, the techs know their patients well. If they're not seeing the doctor, it's prudent to do so. I think if the patient complains that, hey, I have a new wound on my foot, maybe you should check that out,
right,
and get the ball rolling, because once we notice that there are non-healing ulcers on the feet, yeah, the amputation risk has gone up, right?
mm-hmm.
We call this critical limb threatening ischemia, CLTI.
Yeah.
And once it's gangrene or a non-healing wound or even a rest pain in the toes, these patients have a very high major amputation rate. So at that point, I think, if a tech were to notice this and ring the alarm, that would be very helpful for the patient.
Yeah, I kind of think about the dialysis centers, and I'm not a big sports person, guys, but maybe in my younger days I was. But I do know that like there's a certain person on a basketball team that kind of gets the ball and makes sure the play happens, right? And I kind of think about that in the dialysis setting as being the dialysis tech, because they spend so much time. They're the initial collection of data. They have rapport with patients to
Right.
where they would say like, hey, shit, something's going on with
Yeah,
my
they're the ones
foot.
who know the patient the most, 'cause
Yeah.
they get to interact more with the patients.
Yeah, yeah. Let's talk more about the complications, because we've hit kind of the claudation, and we've hit the wounds, and I'm assuming there's weakness involved as well. What else might we see with patients with peripheral arterial disease? And I just got to say that I had a guy come in right before you guys came in that was extremely focused on certain appendages. So can this affect sexual performance in males?
It could certainly. So,
Why did you look at him?
Well, I think
we
we're
we were just talking before this about how I'm having. No, I'm kidding.
I'm not
Trade-off,
I'm
huh?
not suggesting his ED here, but
I'm not
he
either.
could,
I just gotta
be an
make a
expert.
joke.
I don't know.
Mark's regimented. He likes to go in order. We're going in an order
Hey,
here.
I went
he
last,
wants,
you went
yeah,
last.
he wants to keep that order.
All right.
Or maybe I do have a problem and I just don't know it yet.
His wife's pregnant with the third
Oh,
kid.
no,
So
okay, yeah, you're good, man. You're
She's
good.
fine.
Congrats.
Thank you. I would say that, so certainly aortoiliac occlusive disease can present as erectile dysfunction because there's a lack of blood flow to the penis, and it causes an issue with creating the erection rather than maintaining the erection. So that's certainly a possibility if that's what you're asking.
Yeah, absolutely. I mean, I've seen some pretty extreme stuff in the dialysis world, right? Calciphylaxis. And I just remember a specific occasion speaking to a patient that he was eating a big meal. And I was like, hey, Mr. So-and-so, like, I know you take binders. Where are you taking the binders right now? I don't see them. And he was like, F that. Like, I don't feel any different when I take my binders, and they cost me money. So screw that.
Right.
And we kind of went through like some images on Google, and I was like, hey, I just want to kind of show you some of the long-term type of worst case scenarios here, and showed some calciphylaxis pictures. And we got to a picture of of a penis, and he was like, wait, you're telling me that I can, if I don't take my binders, that I could, that can fall off, or I could loosen. I was like, this is a little extreme, but yeah, man, it's not going to be the first time. And after that, guess who was taking his
Taking them.
binders religiously? I really feel like if you don't understand the consequence of your decisions, that it's too, it's hard now, hard later, right? And nobody wants to have that hard later. So I can't help but think of PAD after 45 years or 47 years of life, but 25 professionally, and how little I know of it, as I'll just say it, kind of a dialysis tech nerd. Like, I make it my business to learn more, and then think that more people need to understand this because of the percentage of people that you just told us have this with ESRD. But then let's go, upstream of that and say, how many of us could be sitting on this that are not in that situation? Guys like me, 47, high cholesterol, a lot of desk time. Does that have anything to do with it?
Of course. Yeah. I mean, immobility, sitting down, eating all day, obviously that will change your metabolic profile, and it increases your risk of diabetes, metabolic syndrome, ultimately end-stage renal disease, and for sure peripheral arterial disease, right? So, all these things matter. This is unfortunately mostly a lifestyle disease. Even if you have a genetic predisposition, as we know, type 2 diabetes,
Right.
There's a misconception that type 2 diabetes is purely lifestyle and type 1 is purely genetic.
Right.
It's probably wrong. Type 1 diabetes is typically a viral infection when you're young. Type 2 diabetes is a mix. You have a genetic predisposition and there's a lifestyle component, right? And you can't do anything about the genetics, but you could do something about the lifestyle.
Right.
And so I think if you can target that, you can decrease your risk of real major complications of diabetes, one of which is PAD and CLTI.
Yeah, that's I mean, you just blew my mind with the mix of the genetics and the environment or the lifestyle.
Right.
I think that's worth diving into a little bit, because I'll admittedly, I've kind of felt that way, and a lot of literature has kind of led us to that road of type 2 diabetes is a lifestyle matter. And we hear a lot of people that will say, I'm type 2 diabetic because dad was diabetic and mom was diabetic, uncle was diabetic. So I just want to kind of get a little lens on whether that predisposition is something that can be dealt with through the lifestyle. So in other words, great lifestyle, predisposition, can you avoid type 2 diabetes?
You can certainly avoid it. Some folks can't avoid it, but you can manage it, right? At the end of the day, it's it's a hybrid disease. Part of it's lifestyle, part of it's genetics. The genetic component that you can control with your lifestyle, that's called epigenetics. So you can epigenetically control or modify your risk of type 2 diabetes and the complications of it. And I think that this is a hard thing for folks to understand. You might have family members that don't have this issue. They can eat whatever they want.
Yeah.
They'll never gain weight. They'll never have an A1C above 5, and they eat like garbage. And you can eat just like them, and you'll have an A1C of 7.5, 8, and you have diabetes.
Yeah.
And so it takes a lot more work on your part just to understand how you can control the genetics of your disease. It's called epigenetics. And that's the one thing that we as humans can control. Even if we've been passed a gene on, we can control how that gene is expressed. And that's called epigenetics.
Any I don't know, holistic type of preventions or remedies to this? I mean, does it require, and we'll go down that road, but does it have to get to the point where they come to see you, or are there other type of therapies that, whether they're, holistic in nature and kind of folklore type of remedies, or maybe more towards the regenerative and the anti-aging and the longevity type of things? Anything that you all would say is, I don't want to, I know you probably wouldn't be able to make a claim or an endorsement behind it, but is there anything that people are doing that are keeping them from getting to this point with those predispositions?
It's funny you use the term longevity, because the same conservative measures that help with diabetes also help with longevity to a certain extent. We're hearing a lot about these blue zones and the type of lifestyles that the blue zone people live. We're hearing about the type of things that billionaires take to live longer, such as metformin. I like to boil it down for patients when I describe it to them in two ways, right? We've learned that sugar in your blood is bad, or high sugar in your blood is bad. You obviously need a certain amount of sugar. Your brain needs sugar, your organs need sugar, and guess what? Your skeletal muscles need sugar. And most of the exercise we do, specifically the long-term low resistance exercise, uses a lot of sugar. So if this is a disease of having high sugars in your blood and you're predisposed to it, the two simple ways of lowering that risk are lowering your sugar intake and increasing your skeletal muscle, which basically means exercise, right? And if you do those two things, you're keeping that sugar at least at bay. You may still have an A1C of 6.57, but it's not going to go to 10. And that's really where we start to see the major complications above 7, right? If it's consistently 8, 9, 10, then you start to see the end-stage renal disease, the CLI, the critical limb ischemia, coronary disease, etc.
Got you. So Veronica, you're getting a case, a referral.
I know, right?
So when I'm a physician and I'd like to know that as well, perhaps from you, who are the most common referring physicians? Are they primaries? Are they podiatrists? Are they nephrologists? Endocrine?
It could be nephrologists or podiatrists that we're seeing the referrals from.
That's the most common.
Those are the most common ones.
Got you. So let's go down the road of treatment then. If I've got the manifestations that you all discussed, if it's to the point where I'm actually, I don't know if it's the right way to say it, a qualified referral, what can you do for me to help with peripheral artery disease?
It's a good question. It's a loaded question. It's a second podcast episode.
But you guys have open spot where I can throw a rock to your facility.
Right.
Up the street.
Look, you have to have, not everyone with PAD needs an intervention. We have to say that right off the bat. And there are bad actors there, right? You don't want to be scared with the concept of limb threat or amputation right off the bat. Okay. We have to put that out there because there are bad actors. That being said, if you have CLTI, critical limb threatening ischemia, that includes rest pain and tissue loss. Tissue loss includes a non-healing wound, usually a couple months. It's not getting better, or gangrene. All right. And that's never going to get better. That's dead tissue. You need something, period. 100% of those patients need to be evaluated for an intervention.
Okay.
Going down that spectrum that I described earlier, claudicants. Not every claudicant needs an intervention. Claudicants that have lifestyle limiting claudication, meaning I'm a postal service person. I can't do my job. I need something to allow me to do my job, right? That person needs something, okay? Patients that have the finding of PAD on an ultrasound or a CT scan that are completely asymptomatic don't need anything.
Okay.
Why? Because our interventions are not risk-free. And that's important to know.
Absolutely.
The point of an intervention is to reduce the risk of amputation. I don't want to increase the risk of an amputation with my intervention, but inevitably I will, right? So the risk and benefit ratio has to be studied, and the benefit has to outweigh the risk every time. We have a couple general ways of treating PAD in patients that really need treatment. One is open vascular surgery. The second is minimally invasive endovascular surgery.
Okay.
And you can argue as to what's better, but it's really a complex situation to discuss. We'll see if Mina wants to touch up on that.
Well, the way I phrase it is it's very patient specific, and so it depends on several factors. It depends on how sick the patient is, if the patient can tolerate one or the other, the anatomy of their occlusive disease, right? They can have a single level occlusion, right, which is just an occlusive artery in one location, such as the superficial femoral artery in the thigh. They could have multi-level disease. Oftentimes we get smokers and diabetics with end-stage renal disease on dialysis. So they have aortoiliac occlusive disease, fempop disease, and tibial disease, right? So there are so many things that play a role. How does the wound look if they have a wound? Do they have rest pain? It really is a second podcast, but what I can boil it down to is it really depends on the patient. Can they tolerate an operation? Can they tolerate a bypass? Do they have a good vein conduit or some kind of conduit available for the particular bypass? What's the target of the bypass? Are we going to a big artery or a small artery near the ankle or the foot? Right? All those things play a role in the amount of success that we're going to have with a treatment plan. So we have to come up with that, and it takes sometimes weeks to months to come up with that.
Gotcha.
Hence the importance of knowing this and referring the patient earlier on.
So there's no like plasty type of procedure for this. It's going to be a bypass.
No, there is. There's plenty of plasty, but it depends on what the patient's suffering from, right?
Gotcha.
We've come to learn angioplasty alone. We call it POBA, plain old balloon angioplasty. We basically stopped doing that. I mean, we've found out that there are so many better ways to treat someone from an endovascular means, right? There's stenting, there's angioplasty with stenting, there's drug-coated balloon angioplasty, there's atherectomy with or without all of those things, right? Atherectomy meaning a small device that chisels away, and it's kind of like a boring tool. That
Roto-Rooter.
Exactly. Roto-Rooter. And so there are so many devices, and that's why it's just amazing to work with engineers and come up with these devices and learn what we can do to help patients. But there are so many different combinations of all those things that can certainly help us come up with a plan.
Yeah. Can you guys maybe dive in a little bit? I just want to make sure we do have a diverse audience. And I think understanding the issue of PAD and the symptoms is a great starting point. But when we dive down the treatment, I think it's pretty common ground to understand that patients in dialysis specifically go in for a lot of different sort of plasties, and they need a balloon in there.
Sure.
But when we talk about bypass, I'm not sure that the dialysis audience 100% understands what a bypass is, how it's achieved. Can you dive into that a little bit, Dr. Mark?
Yeah. Look, in order to improve your blood flow, we need to bypass an occluded artery or an artery that has a severe stenosis, severe blockage. And you have to have a point A. A point A has good blood flow, and a point B. Point B leads to outflow, typically into the foot, towards your wound, towards where you're having pain, etc. And so that's what a bypass is. It's kind of like a coronary artery bypass, right? We have to bypass, or like the Sepulveda bypass. A lot of people like to understand this in terms of basic LA traffic, right? If the 405, which is your main artery, is blocked, you need somehow to get around it to get blood down to the foot quicker.
Wasn't that just blocked yesterday?
It's always blocked.
Oh no, it's 5, right? I don't know. Like I don't remember.
That's the 101.
101, yeah, right. Yeah. We saw like a big mess on the freeway, right?
That's not a block. Yeah, that's beyond a blockage. But anyway, we're not going to go there. The point is to get from point A to point B, right? You have to have a point B. And some people don't have a point B, and that's another topic. We can talk about that later. But assuming you have a point B and you have outflow into the foot, that can help heal your wound, heal your pain, things like that. We use the conduit that we like to use because it's got great 5 to 10 year data, is the greater saphenous vein in the leg.
Okay.
And we'll take that vein. If it's in a single segment, it's really the best conduit to get you pulsatile flow down into the foot and help heal your wound. Now, your next question should be, how many patients in this cohort have great single segment saphenous vein? And it's not a lot, right? You need a 3 millimeter vein. A lot of these folks don't have that. What's the next best step? And that's really up for grabs. We don't know. So that's really between angiography with intervention and using some other conduit. We know that the other alternative conduits for open surgical bypass really don't perform that well in the long term.
Mhm.
They're probably as equal as doing some sort of endovascular intervention. And I think that's where we can really help. This is an intervention that we can do under local anesthesia,
Okay.
maybe with a little sedation, mild sedation.
Mhm.
It can even be done in the office, believe it or not. A lot of folks do it in the office, but I think it's probably better in a surgery center with in a controlled setting. And if we can get a wire across your blockage, we can do an angioplasty, a plasty as you call it.
Mhm.
We can do the roto-rooter, which is the atherectomy.
Mhm.
And
We're using my layman terms.
we're using
now.
your
All
layman
right.
terms for the audience here. And then sometimes, depending on the artery and depending on the anatomy, we could put a stent in.
Okay.
Okay.
Mhm.
And this is not perfect. This is not a perfect intervention. This is palliative surgery to try to increase and improve the flow of your foot to heal a wound or heal a toe amputation site for a gangrenous toe,
Mm.
or hopefully even reduce some pain for a period of time in the setting of breast pain. But it's something that we can do almost like going to the dentist, 30 minutes, 60 minutes, an hour and a half at most, typically.
And my life has changed.
And you go home the same day.
Yeah.
Yeah.
Yeah, that's insane. I got to ask this question. If I have PAD to the point where I need this procedure and I try and nutrition it away and wound care it away, is that going to work?
Depends on how dense your ischemia is. If you don't have enough blood flow to heal that, it could take months, but within that time period, the risk is infection.
Mm.
If that gets infected, you need a major amputation.
Yeah.
Major amputation is defined as a below knee or above knee amputation.
Mhm.
That's
I
the
mean,
problem.
I just got to think back about my career, like how many times this actually came into the formula of the plan of care for the patient. And it's been, a handful of times where I've seen these physicians come in and, do the scrubbing and the, what do you call it? God, where they pull off debriefing.
Debridement.
Yeah.
And then, the whole nutrition plan and the whole protein requirement, and nothing works. And before you know it, like, I mean, I've had these patients in nursing homes that they came in with one and now they're at 3. I can't help but think that there's a tremendous amount of evangelism that is required here. Maybe I'm wrong. Maybe everybody out there knows about this stuff. What do you think, Veronica? Like, are they?
Not a lot of people know about this, so that's what our goal for them to learn more about what's going on and what causes it, and for us to help them out, at least not to prevent an amputation.
Yeah,
that's our goal.
I mean, I just I think about, again, days in nursing home, days in dialysis center, and first and foremost, I want to make sure you guys all understand that the business and the referrals and all that stuff, that's really, for me, that's just part of helping people to get better. But to see what they go through when they have this limb loss, or they're even discussing limb loss, the emotional side of it, then when they lose the limb, the emotional side of it, the phantom pains, things like this, that it's life pivoting. Again, I just can't help but recognize that the evangelism is strongly needed here. And I'm just curious whether there are collaborations between can you tell me where the center is, by the way? It's again,
it's in
a couple
Bellflower.
blocks away.
Our vascular access center in Bellflower off Lakewood Boulevard.
And it's considered an ambulatory surgical
Correct.
center.
That is correct.
Tell me what that means and why that's kind of a difference.
Right. So it's kind of, we work as a hospital. So we're accredited like a hospital. So we take all the policies as a hospital. So that's where it makes it a big difference. So yeah, we've treated patients as, it's being an outpatient hospital, basically.
Yeah. And what's the benefit of an ASC or an ambulatory surgical center versus, let's say, a traditional hospital setting? Does it help to expedite my treatment? Does it make it an easier journey? Like, what are the differentiators there?
So the short answer is absolutely. So there have actually been a lot of studies on not just patient satisfaction, but outcomes in an ambulatory surgery center, specifically for dialysis access issues and peripheral arterial occlusive disease, surgery center versus hospital and inpatient. Uh, and it boils down to efficiency. It boils down to being able to treat that patient in a much more efficient manner versus what might happen in a hospital. And I'll break it down for you with a scenario. Let's say I'm in the surgery center. My partner, Dr. Becker, for example, is doing a fistulogram. He notes that the fistula is thrombosed and his endovascular techniques are not going to work. In a surgery center, he can just come out to the office. I'm sitting there doing my own cases, tell me, hey, Mina, go take a look at this patient. I take a look at the patient. I quickly evaluate the patient. I know what that patient now needs, and I book the patient for surgery within a week or two because we have control over the OR. We have control over the timing.
Yeah.
We understand the importance of this versus perhaps other cases. Now let's take that same scenario in a hospital, right? A lot of other players in place now.
Yeah.
The interventional radiologist does a procedure. He consults surgery. Surgery may or may not see the patient that day. The patient doesn't want to just stay in the hospital. They get discharged. Come see me in my office in 2 weeks. Okay, now I evaluated the patient. Now we're at the stage where I did that 10 minutes after Dr. Becker's initial procedure. We're doing that 2 weeks later.
Okay.
Now okay, you need an operation. Now I'm talking to the hospital scheduler for the OR time that's going to happen in a month. Right. So we're talking about 1 to 2 weeks versus 6 weeks.
Yeah.
Well, when it comes to the world of dialysis access, that could mean losing your access.
Oh, yeah.
When it comes to the world of
Or worse.
PAD, that could mean losing your leg.
Right.
Right. So that's why the outcomes are better in the surgery center. Now, like Mark said earlier, there's a lot of bad players. There's a lot of people that unfortunately take advantage of that situation and do unnecessary procedures. So we have to fight the role of saying, hey, look, we're in this for these reasons. We're going to do what we can to help you for the right reasons. But yes, this is a much more efficient system.
Yeah.
This is the much better way of doing it.
Yeah. I got to say that, I think we've been pretty lucky, Paco, that we've, when we talk about bad actors, right? I definitely want to kind of touch on that with all of you. And definitely we won't go down any organization or individual roles, but I'd really like to understand that. And I think Paco, he's been with us since day number 1 producing this podcast. We've had really a strong alignment in the individuals that come and sit across this desk, that they're doing this to improve lives, that they're doing this to save lives, that they're doing this to save the turmoil, as you said, of unnecessary, and in some cases, kind of the business of return business. So I'd like to go down that road a little bit. Unnecessary procedure. The type of tools, the type of instruments, the type of stents, the type whatever it might be. What are some examples? And again, without going into specifics on organizations or individuals, what are some of the things that you see out there? And I'll just give a little color to this. Again, we listen to professionals. We have stories from patients. We listen to their side of the story. And in recent news, we've seen a lot of crazy stuff regarding denials and delays and things like this. And what I'm hearing from you all is that you really reduce those delays. I'm sure there are challenges from the reimbursement aspect of it. So let's go down that road on what are some of the bad actor actions, and then what are the challenges from a reimbursement, from a referral, from an authorization perspective, whether it be from a health plan, from a health plan. Anybody?
Yeah, that's it's loaded. That when we talk about bad actors, we talk about fee for service in your own outpatient center. Typically, these are not ASCs. Typically, these are what have historically been called OBLs, office-based labs, and those were created to do good. Those were created to reduce the costs for CMS and for the health system as a whole. and to create an efficient system to get patients in quickly for the interventions that they need. On the flip side, you know, some folks were treating patients that didn't need to be treated. We don't want to scare folks on this podcast and abroad into thinking that you're gonna need an amputation because you have some risk factor.
Right.
That's not enough, right? We've been very clear about the type of patient that needs to be treated. Symptomatic PAD.
Right.
Right. And not any claudicant, not any symptomatic PAD. Patients definitely with tissue loss, patients with rest pain. You need to go to a center that has comprehensive vascular care. These are physicians that will assess you from A to Z and really parse out why you're having these symptoms, if you're having symptoms, or if you have tissue loss. That's almost a guarantee. If you have tissue loss and you have PAD, you probably need something. So that's the bad actor part of it, where you might have pain that's not related to PAD and you get an intervention, or you might have a finding on an ultrasound, you get an intervention. That's not what we're here for. We're here for reducing amputation rates and ultimately saving lives. Because if you're in a situation where you need a below knee or an above knee amputation, your mortality within 1 to 2 years is very high.
Yeah.
It's close to 50%.
Wow.
Now, that's twofold. It's not just because of the operation. It's actually because you're an end stage disease person,
Right.
end stage PAD. So that's really the bad actor part of it, right? In the ASC setting, it's a regulated setting. I think you see it a lot less. And this is we're talking about an ASC setting here.
Yeah.
And so you know, we're trying to look for patients, and it's not just early on. We'll see patients early on and treat them medically, but we really want to see patients that have that tissue loss because their amputation risk within 1 year is close to 50%.
Oh,
and that is the risk that we want to really reduce.
yeah.
If you have rest pain, your major amputation, and I'm talking about major amputations, BK or AK, below knee or above knee amputation, not toe amps. Toe amputations are going to happen, and I think patients need to understand that this is part of it. You know, we're not going to be able to recanalize a sub 1 millimeter vessel into your toe. That's probably not going to happen. So we try to save toes, but we can't guarantee that we're going to save toes.
To where you can work with the vascular.
We want to save your foot. So you might get a transmetatarsal amputation, hopefully at worst. So you could still walk on that foot and not need a below knee prosthesis.
I gotta say, I'm a little bit scared, man.
We don't want to scare people on this
I'm
podcast.
scared,
We
man.
want to educate people, but
so
yeah.
I gotta stop sitting down at that desk, and I'm trying to get a lot of things under control, including cholesterol. I'm not pre-diabetic, or not diabetic at this point. But Veronica, aside from the procedures, I know that in my experience with you over the years that you've been out there like in the trenches with people, educating them on what to look for, when to refer. Is there a place, is it with you all, are you producing evangelistic type of material to say this is how you prevent it? Because I'm not trying to pick on this, but it seems that we're treating at the point it needs to be treated. So is there any onus on, say, hey, you don't want to come here, this is how you do that from the trenches?
All right. So basically right now we're educating on, you know, what we're doing here with us, right? But yeah, probably with the doctors, we could come up with more things that we could help the patients, you know, from preventing all these things. So.
Well, thanks for honoring us with that, because we feel very privileged to share something like this that not many people know about, but is affecting so many that is actually in our audience base. And then, as you said, perhaps 10% of the general population. So one, getting awareness of what it is that is what this is. I think we've kind of alluded to the type 2 diabetes, to the hypertension, to the end stage renal disease. So how do we reconcile kind of like preventing diabetes, preventing hypertension, which I think a lot of people evangelize that it could lead to CKD, But how do we put that in the same conversation of peripheral arterial disease and the complications that lead to limb loss and other sort of amputations?
The nice thing about it is they're all part of the same group of diseases, right? These metabolic diseases are all linked.
Mhm.
It just so happens that the things that you can do for yourself to lower your blood pressure without taking medications are the same things you can do to lower your average blood sugar readings, or your A1C as we call it,
Mhm.
are the same things that can lower your risk of CKD or end-stage renal disease.
Yeah.
It sounds frustrating to hear it, but it really does boil down to diet and exercise. So what
Yeah.
does that mean? Because patients get so frustrated when they walk into a doctor's office and they hear diet and exercise.
Same thing they
Does
heard
that-
at the primaries.
Exactly.
Yeah.
Does that mean I have to eat fish and vegetables for the rest of my life and run 2 miles a day? No, that's the problem, right? We
Yeah.
have to make small incremental changes
Mm.
and do them at the right time. Does that mean I can never have a candy bar or a piece of candy again? No. But if you're going to wake up in the morning and the first thing you eat is a piece of candy,
Yeah.
well, you better expect that when you check your blood sugar, it's going to be near 200, right?
Mhm.
Or
Mhm.
150 if you're not, if you're not diabetic, or 130 if you're not pre-diabetic.
Mhm.
The point is, these things matter, and there's a lot of them. But simple actions can help lead to long, chronic benefits, I can say,
Yeah.
long-standing benefits, right? Take something as simple as taking a walk, a 30-minute walk after you eat a meal,
Mhm.
specifically a high carbohydrate meal. That can help limit the sugar spike, right?
Mhm.
Something like eating a high protein, high fat breakfast rather than a high carbohydrate breakfast.
Yeah.
These are the things that are coming out now in the research that are very important, and it shifts your mentality from never having something to having it at the right time. If you
Yeah.
need a piece of chocolate, have it after you've eaten a high protein, high fat meal first, and
Mhm.
that'll limit
Mhm.
your sugar spike, right?
Yeah.
There's thousands of things like that, but those are just very simple things to incorporate into a diet to make some major changes.
I heard a social media influencer recently talking about universal healthcare and basically making an online demand that we go to universal healthcare, but we have all of the candies and sodas and all the crap food that we eat pay for that. And, it kind of struck me as like, I understand. Uh, but at the same time, we have that choice to put things into our body. So it's so important that we make good decisions, right? I'm just curious your guys' stance on these foods that we have that make it very, very easy, especially in urban areas, to run yourself off a cliff and into type 2 diabetes, hypertension, peripheral arterial disease. So let me ask you, Veronica,
Mhm.
from that aspect of it, what are your thoughts?
I mean, it's very easy to just eat the junk food because it's easier for you to get it right. And of course, it's good. But yeah, you have to look at the bright side about all these things that cause it, like the diabetes, the hypertension that cause for you to have either ESRD, end-stage renal disease, or going into PAD. So yeah, there do more education on that.
Yeah.
On
Yeah.
trying to prevent this.
Yeah. I mean, do any of you feel like I am seeing certain elements of food being banned and outlawed now? Do any of you feel like that's the solution from a regulatory perspective, that there could be certain things that should not be available? I heard something recently that children should not be able to buy anything with sugar in it, and it was like a biohacker guy, right? If children should not be able to buy anything with sugar in it, they're not allowed to buy alcohol, or in California buy cannabis, right? But they can go buy sugar that is perhaps just as dangerous to them. Do any of you have a stance on that, on kind of the systemic or systematic causes to some of these things, and how to approach that?
I mean, it's clear that this is probably what's killing us the most. Putting regulations that ban things like this, that's I think that's a tough pill to swallow. Obviously, this is we live in a country where we have some freedoms, But I think there are things that people need to know. They need to be aware that it's killing them.
Yeah.
I think that's where I probably draw the line, and that's where people need to really for us, it comes down to patient education, right? So if
Mhm.
folks understand what's killing them and they want to keep taking these things, then there's an element of personal freedom, and
Right.
there's an element of I think societal burden. And I think it's tough to take one side or the other, but I think we have to kind of straddle that and find the balance.
Yeah, I agree. I've always thought about as long as I know, if I know, let's talk about smoking. If I know that's bad for me, I know it can cause cancer. I can know it can cause all of these vascular disorders, things like this. If I know and I choose to do it, I'm self-managing my way into disease. If I know and I choose to not do, then I'm self-managing to keep myself out of it. And I do take, admittedly, a lot of pride in the ability to make that decision. But my only concern is that there are people who don't know, and how do we bridge that gap? Because I do agree there are certain privileges here in the United States that, it's a capitalist country, right? Like,
Right.
I'm going to sell sugar because it makes a lot of money. I'm going to sell alcohol because it makes a lot of money. I'm going to sell nicotine because it makes a lot of money. So let's dive down that road on the nicotine basis, or let's just say the smoke basis, because you mentioned that smoking could be one of the factors here. Are we talking about cigarette smokers? Are we talking about cigar smokers? Are we talking about vapors? Are we talking about cannabis consumers? What are we talking about in that regard? Is it all the above?
Well, the data that we have now that we can really rely on is cigarette smoking. We don't have as much data on cigar smoking, marijuana smoking, etc. E-vapes are obviously something that's new and
Mhm.
trending. We know that they're unhealthy to a certain degree, but we can't state yet that they're as unhealthy as cigarettes, right? There's a lot more in cigarettes than just nicotine. And there's a lot in the smoke that's inhaled from cigarettes that causes inflammation of the arterial wall, which
Yeah.
then leads to atherosclerosis. So
Mhm.
that we know is certainly terrible. We don't know that e-vapes or marijuana, et cetera, cause the same amount of inflammation,
Mhm.
but there are other things that could be unpacked that have yet to be unpacked about those as well.
Understood. What about stress, sleep, these sort of things?
Sleep's important. We know that sleep is necessary for de-stressing. Its relationship to PAD, I think, is not clear. I think there's probably a relationship in the data to coronary artery disease,
And diabetes as well, right?
and to diabetes,
Yeah.
and to various hormonal spikes that
Mhm.
can affect your blood sugar. But I don't think we have a clear link to PAD. But obviously, with you need to get rest, you need to get sleep, you need to make sure that you're not stressing, you're de-stressed. Those are
Yeah.
very important things for overall kind of holistic health.
Veronica, do you feel like people think about sleep as a preventative medicine?
I don't think they think about it that much, but yeah, it is something that, they should be thinking about. That's one of the causes, it's you need to sleep good in order for you to be, feeling good,
Yeah.
Yeah.
So I know a lot of the people that I really admire. I would coin myself as a wannabe entrepreneur, right? Or a serial entrepreneur. A lot of people I look at, the Dan Penas of the world that, it's like, hey, you sleep when you die, right? Like you got shit to do, right? And I've always had that mentality as well. But I got to tell you, uh, probably when I broke 45, like I took a real appreciation for sleep and what it was doing to my body, my stress levels, my blood pressure, things like this. And I've made it a much more conscious effort of it. Do you find this? I got to, I want to ask about backgrounds here now. You all are highly successful in the world of healthcare and providing life saving, limb saving, and life altering procedures. How are you doing in regards to your health and managing stress and managing sleep? Let's start with you, Veronica, because I know that you are in the office and
Mhm.
you're making sure that referrals are coming and relationships are made. And I'm guessing that there are probably nights that the phone is all night long.
Yeah. Wait, yeah. Sometimes, not all the time, but yeah. Um, Stress for me, actually working with Dr. Becker now, it actually, no, I like it.
good.
I enjoy it. I
All
enjoy
right.
what I do, what I do for him,
I saw
working
him
with him.
slip you the 100 earlier.
No, not at all. But yeah, I enjoy what I do, my work. It helps me, it motivates me,
Mhm.
to help patients, to be able to help them
Yeah.
and getting them much care as possible, and educating patients to, we don't delay care. We make sure that the patients get in on time and we treat them, So that actually helps me, it helps me and motivates me to take care of myself more.
I gotta agree with you. And I've known Dr. Becker for over 15 years. And when I first met him, he kind of gave me some grief because I was young at the time and like a young knucklehead, right? But it always came through that like I am doing, and the culture of my organization and everybody around me is what's right for the patient, not what's right for us.
Right.
What's right for the patient. So that's got to be really gratifying. And I think I'd probably sleep a lot better at night as well.
That that you're doing something good for patients.
Yeah, that there's no bad acting
exactly
in this formula. How about you, Dr. Archie?
In terms of what? De-stressing?
Yeah, as far as just kind of managing, you're a vascular surgeon. I know that you're at the ambulatory center over here on Lakewood Boulevard, and you're a colleague of Dr. Becker. Are there other areas that you're practicing?
Yeah.
How do you manage life?
Yeah.
Do you guys have children and
well, I don't
spouses
have
that you can spend time with?
I don't have children, so I don't have that stress. But I am at Harbor UCLA. It's a level 1 trauma center. I think there's some stresses that come with that. But overall, I
Yeah.
think we gotten to the point where we kind of get used to the ebbs and flows of this practice. And the most stress we'll have is when we're on a call and we have stressful situations, but that's not every night. No more than once a week or so we get that. So I think I've been able to manage my stress pretty well. We talked about sleep. Sleep's important. I make that an important part of my life. Exercise, utilizing your muscles, making sure you're trying to eat well whenever you can. Those are really things that can help.
Yeah.
Yeah, I would second that. I mean, when I was in medical school, second year medical school, I was 50 pounds heavier than I am now.
Oh, wow.
And I remember actually the lecture that we had that changed my mind as to changing my diet and changing my exercise habits.
Was this weight or muscle?
No, this was weight. This was fat.
Okay.
This was probably even more so than that, because at that point I lived a sedentary lifestyle. I had high blood pressure as a medical student. We used to have these labs at UCLA where we check each other's blood pressures, and mine was in the 140s.
Oh, gosh.
In my 20s.
Yeah, they're like, hey, you got to go get seen.
Exactly. And
Yeah.
so at that point, and my creatinine was 1.1, and I wasn't necessarily a very muscular guy. So I was wondering,
You're creeping up
all
there,
these
huh?
things I was kind of worried about. And that's when I made the change. And so when you ask about our own personal lives, it is challenging sometimes when you work in the field of surgery, you take trauma call, etc. Yes, you do interrupt your sleep. And then on the nights when you can finally sleep, family life at home gets in the way, children can't sleep, they get sick, etc.
Yeah.
It certainly plays a role, but for the most part, that's just a temporary thing, right? The focus has to be on a holistic approach to a healthy life.
Yeah.
Sleep, diet, exercise. I sound like a broken record, but it really is very important.
Yeah.
And I never felt as good as when I started to eat right and regularly exercise. And I wasn't really exercising that much, but it was very consistent. And I think that that's the key. And I try to drive that home with patients. Just be consistent. Even if it's a 20 or 30-minute walk, you don't have to be an athlete. You just have to be consistent. And if you could pull that off, I think they can make big strides.
I just had that lecture or just heart to heart with my doctor regarding cholesterol. And I was like, oh, you know what? I got this, doc. I don't need the medicine. I'm going to just fix my diet. I'm going to start exercising. I didn't fix my diet. My wife did. But, you talked about fish and stuff like this and the good cholesterol and things like this. We've really taken on to that. And she said, Morales, like, let's be real. what are you going to do forever? Don't try and like 180 yourself.
Yeah.
Do something that you can sustain, that you can do forever, make small incremental changes till they become habits, and then keep those going. So I love what you're saying here is that, it can't happen overnight, like this lifestyle to that lifestyle, but it is necessary to kind of check yourself. What's the average age of somebody that's getting PAD?
We start to screen at 65, so 65 is the magic number for us.
65. And do you see patients that are in earlier ages? Is it related to those, like kind of the extremes of those conditions, those chronic conditions?
Yeah.
It is.
Yeah, we see both. We see extreme, PAD from other sources, and we also see essentially non-PAD type of occlusive disease, which are sort of weird zebra type diagnoses. They're very
Yeah.
unusual.
Oh. So let's talk about the networks, and then kind of we'll kind of round out the episode. Building those networks, those evangelistic opportunities. What does that encompass? What care settings? What type of healthcare professionals? And then, of course, let's go to the root of a healthcare team, which is the patient. How do we build those networks? Is it through avenues like this where we get general information out to people who are not hearing about it already, or is it to directly connect with healthcare providers that are going to be making direct referrals?
Well, yeah, connecting with healthcare providers foremost, either with our nephrologists we already work with, or also now I'm going out to podiatrist centers, to wound care centers. So making that network with them, letting them know what we do for them, what can we do for them, and making them easier for them to refer and what they need to send to us. As I said, regarding insurance, they just send it to us, and we'll go ahead and run the insurance, and we'll also ask for the authorization. So making it easier for them to refer to us. And also if they need more outreach or education, we'll also come out and provide that information to their practices as well.
What about those long-term care communities, the skilled nursing, the assisted livings, where you're going to see wounds all day long? Are you guys reaching out in those environments? We'll
probably start at going into that as well.
Do you feel like, whether a percentage, or can you even kind of guess on what percentage of the patients, because we said 65 plus, are coming from skilled nursing, long-term type of care settings, LTACs, things like this?
Yeah, I really don't know. That's a good question. They come from all walks of life. So when they're at the skilled nursing facilities, I would anticipate that because they have more eyes on them, you can say, right?
Yeah.
More clinically trained eyes. There might be actually a lower percentage that are in need, but I would say that, like I said earlier in the discussion, the more people that know, the better, and the most important is the patient, right? And I wanted to circle back to where you kept saying you were kind of worried about yourself. Don't lose sleep over this, because the fact that you already know it and you're watching out for it is a big deal, right? But that's really the goal. Because the majority of the patients that come in and oftentimes come in too late, they just didn't know. They had no idea. And how would they?
Yeah.
Right. I was in medical school and I didn't even know.
Yeah.
Right.
Yeah.
And I had, 4 years of undergrad training and then 2-3 years of medical school, and I still didn't know.
Yeah.
So education is key.
Is this the bulk of your day, PAD, or is it also other vascular type of procedures?
I would say dialysis access and PAD are the bulk.
Yeah. Gotcha. Yeah. Good. So let's dive in a little bit, because you mentioned insurance, and I know quite often some of the most needed procedures tend to get held up in that regard. Are there challenges there, or is it pretty straightforward? Like, you got this, here's your referral, and
there could be challenges, and what we suggest for do peer-to-peer review. That's the easiest way to go around if they're they're giving us denials or they need more information. I think peer-to-peer review so they can understand more
Mhm.
about this, because a lot of health insurance is also, they don't know, what's going on, or they need more information. So peer-to-peer review, that helps with that authorization.
So is that like in the realm of like justification?
Right. Basically.
got you.
Justification. Yeah.
Okay. And that's not standard yet. It really does require a lot of that peer to peer.
Yeah.
Gotcha. Yeah. I mean, that's been a challenge in many avenues with this particular population, even in the home dialysis world, right? Where sometimes home dialysis patients are getting more than 3 treatments a week, and it requires justification. I know that a lot of organizations have kind of figured that out, and it's become a little more standard, but that's interesting to hear that it really requires that direct communication. What does that go like? How's that conversation?
Yeah, generally it includes describing the patient's issues and what is necessary to fix it or manage it. I would say oftentimes it's successful, but every now and then it's not. I will say with Medicare patients, it's not required, so that's nice because
Okay.
a lot of these patients that are 65 and older, plus
They're
or
on it,
minus
yeah.
dialysis acts,
Yeah.
dialysis, they are Medicare. So it's not as common as in other specialties, but it usually goes okay.
So when you say Medicare, so the justification is much easier with Medicare. What about the like the commercial insurances, the MA plans? Is it the same? A little
Right.
more difficult.
It's a
That's
little more challenging.
very challenging
Yeah,
for
those are the
those.
ones where we need, Veronica and the likes of hers help with getting the pre-authorization, things of that sort.
Guys, I'm going to open up a really sticky subject. Value-based care. I saw a face. Is this where you're running into denials, delays?
Partly, I mean, value-based care is important. The concept of value-based care is essential. The
Mhm.
practice of it is challenging,
Right.
right? And so we talked about bad actors earlier in the discussion.
Mhm.
Value-based care is aimed at targeting people who do, or physicians who do, unnecessary procedures for financial gain,
Mhm.
right? And we do want to tackle that, and that is an important thing to fight. At the same time, some of the implementations that are put into place have been put into place by perhaps people that don't have experience in this, and so some of the asks are very challenging.
Yeah.
They're not practical,
Right.
and so it's going to take some ironing out of the kinks to be able to work a little bit better. But yes, that's why you see the face when someone says value-based care, because it's
Hey,
challenging.
yeah. I mean, it's I think it's a great concept. Improve care. Top line. Bottom line is at the reduction of cost. And quite often, in my experience, I've seen high utilizers and high cost patients be the focus of this. And I can't help but think it's a no brainer when you've got a patient sitting in a nursing home that is developing wound after womb, womb after womb, and ending up with amputations that are very costly, that are impacting the actually quality metrics. If that's what you're in it, not you guys, but if that's what the other entities are in it for, is to do the best business, I can't see how this is not great business to improve the healing of a wound, to prevent an amputation, to prevent a hospitalization. Am I speaking in the right terms here as far as what this can do
Yeah.
for a patient?
Yeah, no, absolutely. If you're in this for the right reasons and you're keeping the patient out of the hospital, you're keeping the patient away from sepsis, you're keeping them away from a major amputation. This was the concept behind the OBL back in the day, right?
Mm-hmm.
Conceptually, it made sense to keep the patient out of the hospital.
Right.
And I think the ASC is really a good medium for that because it has just enough regulation to make sure that you're doing the right thing for the patient.
Mm-hmm.
And at the end of the day, if we can keep them out of the hospital, we keep them away from having septic episodes.
Yeah.
We keep them away from a major amputation. We did, beyond saving the patient, their limb, maybe their life, we did save the healthcare system likely tens, if not hundreds of thousands of dollars.
Right.
So that is value-based care.
Yeah.
If you're doing it properly, we are achieving value-based care.
So it should benefit both
Correct.
the payer and, more importantly, the individual who's
Right.
going through whatever it is they're going through.
Right.
And again, that's why I kind of say I'm opening up a sticky subject. I like to keep my ears open. It's a buzzword today for sure. It is definitely a concept that is being attempted, and I'm just hoping that the actors are seeing it from both sides, because I got it. I'm sure you guys got into this for the same reason. Is it wasn't to line your pockets.
Right.
It was to actually have an impact on one by one an individual's life. So let's go down that road. Veronica,
Mhm.
how did you get here? Like, you are a superstar as far as running and building businesses. I've known you for about
Right.
8 years
More
or
probably,
so.
more than that. But yeah.
And you've done great things. How did you get here? Why do you do this?
So I started working at a dialysis center. That's how I saw it all started. So
Hmm.
I didn't even know nothing about dialysis. I was fresh out of high school, started dialysis. That's when when I learned about ESRD.
Mhm.
I was there for a while. I was a vascular access manager.
Okay.
So I would refer patients when they had any Steele syndrome or aneurysms or all that stuff.
Yep.
And that's where I got to go and work with Dr. Becker after
Mhm.
that. So I worked with him at when we had one of the vascular access surgeries. So I worked with him for a while, and that's where I learned the other side of it,
Yeah.
where we do all the maintenance, what we do. So, and also I had also family who were also ESRD, and that made me more conscious and realize, that patients do need more education, and being able to help patients.
Mhm.
That's what actually helps me,
Yeah. Do
And
you feel like that kind of made it more like it imprinted on you
it
more because of
imprinted
the
it more.
personal?
Yes, because of the personal.
Yeah.
Yes.
Yeah, I agree.
That- Actually, Dr. Becker treated my grandmother. So
Oh,
yeah,
wow.
so I trust him.
Yeah, well, that explains a lot.
What we do. Yeah, exactly.
Yeah, that's great. Thank you for sharing that. Vulnerable. I mean, I also grew up around a dialysis patient. My uncle, from the time I was born, he passed away when I was 35, and it taught me that life doesn't stop with chronic illness, and that there's a lot of things that can be done from an empowerment perspective. So I really appreciate what you do at the Access Center, and just to share a little bit, like some of the interactions we've had over the years are, you and Dr. Becker and the team there have invited so many people that are working in the front lines
Right.
to come in and see what they don't see.
Right.
How valuable is that experience?
It's good because they realize that what we do that impacts the patients. So they learn what are the signs and symptoms of the patients. Because a lot of the technicians or nurses are not aware of everything that that why are we treating patients and what we do.
Yeah.
So when they come out to our center and Dr. Becker educates them and they shadow him and they see surgeries and they learn more about the things that we do there.
Yeah.
And it's making sure that we're taking care of the patients.
Yeah.
And it does impact them. And that's when they start seeing more things and taking care of the patients and looking at their accesses, being more aware of what's going on.
Yeah, absolutely. I find it amazing how you guys can walk and chew gum at the same time. The first time I went and saw Dr. Becker in a procedure, I mean, it's a procedure. And he was like actually so attentive to the individuals that were in the room to be able to explain play by play.
Right.
This is what's going on. This is what I'm about to do. That's what that screen is. That's what that person is doing. And it just opened up my eyes to kind of like people think about dialysis. I didn't know there was such thing as a dialysis tech. Well, I didn't know there were all these people working in these surgical centers that have different disciplines, different avenues to, they're spokes to the hub, right? That make this all happen. How about you, Dr. Mark? How did you get here? And you guys both got here. I'm assuming there's probably some sort of common root, but maybe I'm misassuming.
Yeah. No, I mean, it's a loaded question. Obviously, I think growing up, I always wanted to really be a doctor. It was always a childhood dream, and I worked towards that. I went to UCLA for undergraduate. I went to Meharry Medical College for my medical degree and came back to UCLA for my integrated vascular training. why vascular surgery? I mean, we operate all over the body. We do open surgery, we do endovascular therapies, and for me, it just felt right. There's a lot of versatility to the specialty.
Yeah.
You're helping a lot of folks in a lot of different disciplines. We've been talking about PAD. That's a segment of what we treat.
Thread of the fabric.
We take care of end-stage renal patients. We take care of PAD patients. There's crossover there. We take care of aneurysmal disease. Both of us are aortic surgeons. We take care of carotid disease, to reduce stroke risks. And so really it's a versatile specialty. And I think really very privileged to be a part of the specialty.
That's awesome.
Yeah, Mark hit the nail on the head. I mean, the versatility of vascular surgery, it's very vast, and we're able to do a lot. And what sort of drew me to the specialty was being that firefighter, the sort of helper for perhaps even other surgeons. Sometimes we get called by other surgeons in the operating room because they have a bleeding complication and they need our help. They need our help with repairing a challenging artery like the aorta or the iliac artery or vein if it's bleeding. And so that's probably what drew me to it. I remember the shift for me happened in medical school when I saw it was actually a head and neck surgery where they took a sartorius flap. They took a very large sartorius flap, and when they exposed the sartorius, the superficial femoral artery in its entirety was exposed.
Just saw it all.
I said, well, whoa, that's really cool. What's that? And that's when I started learning about vascular surgery. But even before then, we have family members such as yourselves, similar stories that have suffered from diabetes, end-stage renal disease, and they've needed that. They've needed to lean on that for support. And so that played a big role in medicine in general and being able to help patients out.
You guys both look really young, to be surgeons. Do you mind me asking how old you are?
38.
You are young. All right.
Yeah, 36.
36.
That's funny.
Yes, right.
The little kids at my kids' schools think I'm like 50. So thank you.
Yeah, I don't keep my age very well, so I pretty much gonna call everybody young in this room. Even Paco, who's like 50 years older than me, but just kidding, Paco. It's a couple years older than me, but like he definitely looks like he's 20 years younger. And I'm gonna attribute a lot of that to sleep. No familial physicians in your family?
Directly, no. Our parents are veterinarians by trade.
Oh, cool.
From Egypt. We've got uncles in the medical field that are internists. One of them was a PAD patient that actually passed. And but I think that's it, right?
That's it.
Yeah.
Great. Dr. Becker, you're standing in the background. I just want to see if there's anything you'd like to inject on this podcast as far as the team that you've built here. We've met others in the past, but I'm really impressed with everybody. I've known Veronica for a long time, but just kind of hearing the way that you guys have expressed your knowledge and the skill set and really the rationale behind why you do things. It's not a surprise based off my history with you, Dr. Becker. But
we have a very collaborative approach. So the surgeons and interventional radiologists are constantly working together to refine the product and do the right things. And so that's something that they touched on a little bit. Amina and I have had a bunch of different things that if I have a Steele syndrome patient, I'll immediately bring in them and show them the images. So we can do same day or next day procedures.
Pivots, right?
Yeah, so even like a patient coming with a large clotted aneurysm, I think you operated on the same day, right?
Yeah.
Or
this is actually my first day working with them, and he threw this
it's like
complex.
Hey, you're on. Kind of like you today, huh?
Yeah.
Like, hey, you're on.
You're on. Yeah.
No,
Just like that.
That's awesome. I think that should really be highlighted as a differentiator to the ASC that you guys are working at over here on Lakewood Boulevard. By the way, I like going there. There's King Taco right there. Go grab some King Tacos, right? But so sometimes I'll find an excuse to drop in. But I think that's really high value that you've got everything you need there from an expertise level to where you can pivot pretty quickly, right? So you come in for this, but actually this is what is needed, and he can throw the case and the HMP and all of the images to you, and you can make some determination on whether something can be done the same day. So shortening up those procedure times is actually very
Exactly.
excellent. Yeah.
Yeah.
Guys, anything that you would like to share with the audience related to PAD prevention, screening, treatment, complications that we have not discussed?
We've hit it all. I would just harp again on diet and exercise and be consistent. It's really the consistency.
Mhm.
That's all. That's all it is.
Yeah. And just to spin off that, this is a complex disease process, and what we do is palliative, and it really starts with the patient. And once you need a doctor, it really starts with your primary care doctor or your nephrologist or your podiatrist.
Mhm.
And I think if any doubts about what's going on in your periphery, I think there are simple, cheap screening tests that can be done.
Mhm.
ABI. We didn't talk about ABIs, ankle brachial indices. These are just blood pressure ratios, arms to legs.
Mhm.
It's a very simple screening tool. I think if you can't feel your pulse, that's the next best thing. And if it shows that there's an abnormality, then I think seeing a vascular specialist sooner rather than later
Mhm.
is prudent.
Yeah, I mean, my experience with vascular surgeons and vascular specialists over the year, and I'll tread lightly here, it's been pretty difficult to get patients in. So this is really encouraging to hear that the actual time from referral to appointment, the time of the appointment, and then even pivots that in some cases could say, hey, you got to go home and come back, can be shortened up. So I'm really encouraged about what's going on. I'm looking forward to learning more. I do want to share a little bit about some of the interactions and some of the things that we're doing on the podcast with you all. Today's episode is actually formatted for CE. So you guys saw the outline. We kept it very genuine, but we've absolutely achieved the objectives for today as far as the audience coming away with an understanding of causes, prevention, treatments, and complications. So I thank you for that, that professionals can walk away with an enhanced knowledge. But even more so, I'm more thankful that the people that we've had come join our podcast because they're watching things like fighters and tattoo episodes and entrepreneurs that don't really care about this stuff are hearing things that they may actually be experiencing. I think about, truck drivers and the sedentary lifestyle that you talked about, which, let's face it, there are so many people in the United States today that are sitting down all day long. Me, one of them, because I have to manage from a dashboard through quite a bit of the day. So small, subtle changes. I hear you loud and clear, Dr. Mina, that we need to take on lifestyle changes or lifestyle enhancements that we can sustain for the rest of our life. I have taken away a lot of just things that I've really known in the past, but more conviction in the need to manage the diet and avoid what I can avoid. But then also that we've heard from you today that there are also certain characteristics as far as the genetics that we should probably be more aware of. And in some cases, perhaps we're being preached at in a way like my thoughts prior to today that, hey, you can prevent diabetes 100%. There are predispositions to that. So it's very, very important that we're aware of that. We do have some exciting things coming up in the upcoming months, guys. You guys know that it's Kidney Month coming up in the month of March. March 13th is World Kidney Day. We've taken on through the podcast quite a few stories of individuals that have chronic kidney disease, end-stage renal disease, transplants from cadaveric donation, transplant from living donation. And we have an exciting art show that I want everybody to take this date down, March 1st, 5 p.m. And we'll be here in Long Beach. There's an art show that is highlighting stories of patients, specifically one patient that has gone through or is going through peritoneal dialysis and is seeking organ transplantation. But we've also brought in other patients that maybe already have transplants and are going to be speaking on behalf of what that journey looks like. We have living donors, one from the National Kidney Foundation that will be talking about that experience, as well as kind of all of the stuff that National Kidney Foundation does, and other organizations like the UKRO, which is working on the synthetic kidney right now at USC, to be able to just bring more light to this. And one, hopefully we can encourage kidney health, vascular health. Two, we can encourage empowerment if you already have it on how to slow down the progression or to get proper treatments. And then what we'll call the golden goose is that people would be able to find their way to a transplant list, find their way to living donation, and maybe in the very near future, there are other options towards that. So I would love to see all of you there. We'll share information with you and all of the audience. I want to thank each one of you, Veronica Gonzalez,
Yes. Thank
Mark
you.
Archie, Dr. Mark Archie,
Thank
and
you.
Dr. Mina Archie for joining us on the podcast. It's been
Thank you.
nothing but a pleasure, and I look forward.
The Archie brothers arm wrestling.
Oh, that's right. We have an arm wrestling contest that we got to do here. But Dr. Becker, Dr. Anthony Becker, who is, you are the medical director at the ASC over there on Lakewood, right?
Yes.
And as well as a founding partner, correct?
Correct.
Yes. For all of the support over the years, not just in bringing great people like this to the podcast, but I can tell you we've sent, 100 people over to you to hear firsthand what's going on in that center, and they walk away and they go out into the field and they make a difference. So I give a lot of that credit to folks like you that are willing to share your expertise and break down the tough stuff to a level that people like me can understand and apply to our lives and to our practice. So thank you all so much.
Thank you very much.
Thank
You guys have an arm wrestling competition to hit. Any bets online, you place your bets now.
Place your bets.
Dr. Mark Archie or Dr. Mina Archie. You guys gonna do it?
You want to do it live?
Yes.
Okay.
Sure.
Okay.
Yes. All right. So
I'm
closing.
gonna have to come across or something.
Yeah,
How
you
are we
can-
gonna
you
do
come
this?
take my spot.
Is that gonna work?
I got long arms.
I need to know the history too. Who's got, what's the count already on this?
Mark's
It's
probably
it's probably him, honestly. Ever since he lost 50 pounds and
They both said it's the other one, right?
Here we go.
wait, hold up. Okay.
All right.
Who's calling it?
I'm calling it. Ready? Go.
This might take a minute.
Uh-oh. Claudation.
Arm claudication.
He's gotta be here. I can feel it. I can feel it.
Stamina. Come on, man.
Oh man.
Who's gonna give?